Well, thank you very much for the opportunity to chat with you about HIV. So this is going to be 30,000-foot view of HIV. You're going to be, and stop me anytime because this is conversational, to be fun. If I try to make it fun, ask questions because that's how we learn and get our attention. So we'll go very quickly. The whole point is to give you a overview of HIV, not in any sort of detail, but we'll talk about the epidemiology so you know the big picture, virology, immunology of it. It's so interesting, right? This virus is really has very intimate relationship with the host immune system. We talk about pathogenesis, natural course of infection, opportunistic infection, treatment prevention shower. Wow, this is like 10 lectures in one. So start out with the 1981. This is one disease that happened in our lifetime with so much changes. And so I think when you think about infectious disease, I'm an infectious disease clinician and many things I treat hasn't changed forever. But HIV is what changed dramatically. And so the history is really fascinating. 1981 is where we first got report of these outbreaks of this pneumonia, this serious pneumonia. Pneumocystis is a fungal infection of the lung, and we only see it in very immunocompromised people. So we see people coming down with these and die from it. We saw people with Kaposi sarcoma, a type of skin cancer called Herpes virus, and non-Hodgkin lymphoma. And so there's a case series in a big city like San Francisco and New York. And it's not until 1984, 3 years later, that HIV was successfully isolated by Luc Montagnier from the Pasteur and working in collaboration with Robert Gallo from the NIH. And it's really interesting, it's a virus, so very difficult to grow virus. Why? Because virus needs host to be able to grow. It doesn't grow by itself. And even so, we knew it was we know it's probably a virus that we couldn't really isolate the pathogen to try to grow it with cells, but it still didn't grow until we activate the cell with some brilliant idea to activate it, and that's when we're able to grow it. So not until you isolate and grow the virus that you're able to then develop antibodies, right? So you got the virus, you then isolate it, you know the genome, and you can inject it inside animal host, develop antibodies, then you can develop a test to screen for antibodies. Once you get HIV isolated, things begin to develop, including drugs. So the first drug that was developed was nidopodine AZT that was developed for cancer treatment, and we tried to use it because we didn't have anything at that time in 1987, and it worked. These are the three people that got Nobel Prize in 2008 for discovering and isolating HIV. And so the theories of how HIV transfer from simian immunodeficiency virus to human, there's two theories. One is natural transfer, the other one is human transfer. So the natural theory published in Science 2000 was that the simian immunodeficiency virus would transfer to humans through hunting and handling of chimpanzees in West Africa. And the epidemic required urbanization, obviously with population mobility, and that's the most scientific theory. There's also human error theory. During the same time in the 50s, there's oral polio vaccine used in West Africa. That was when it was rolled out. And so people saying that may be contaminated with simian immunodeficiency virus and it gets to people in West Africa. But HIV was never recovered from this vaccine in subsequent studies, so it remains a theory. So where are we with HIV pandemic? 85 million people infected, and half of them, more than half, died. So right now, 40 million people living with HIV. Half of them are women. 95% are living in the low and middle income countries, right? But luckily, this virus started here in the United States. In Africa, we know, but it's really right in Africa because of advances in medicine. We can diagnose PCP, do these things. In some ways, it could have cured a lot more if it didn't reshape in this part of the world, because all the science and technology are here. And so advance can be made much more quickly. But as you know, 70% of HIV are in people living in sub-Saharan Africa, 20% living in Southeast Asia, and the rest are in Europe, North America, and Latin America. Right. So we got 7,000 people infected a day. 7,000 people are still infected per day, and 5% of those are children under 15 years old. So it's still a big problem, despite the fact that we've gone a long way. We still haven't done very well in terms of prohibiting transmission. In 2022, a few years ago, 630,000 deaths per year. 630,000 deaths per year. And that came down from about 1.5 million deaths per year 10 years ago. So numbers reduced significantly, but with antiretroviral therapy, you should expect that it's gone down to very minimum. Right? If everybody gets tested and everybody gets started on therapy, you shouldn't see deaths, right? So we still see 630,000 deaths per year. And that's very important with the opportunistic infection. And so you have a lot of deaths in concentrated high-risk populations that have HIV. So in transgender people, men who have sex with men, injection drug users, sex workers, people in prison, those are the people who are most profoundly infected. So that's just very quick summary of epidemiology. Let's move to virology. It's classified under lentivirus, and so you see lots of Duke investigators are working on lentivirus because they're similar, and that they can use that lentivirus, which is not very virulent, to study how you move different vectors, and etc. You can manipulate genome easier. It's a retrovirus, right? So it's an RNA genome, not DNA genome like most organisms. It's an RNA genome. So the thing about RNA is, who can say something about RNA genome? What's the problem with RNA being genome? Yes.
Maybe it's not as stable as DNA.
Not as stable, what else? I'm going to make it as a question thing, otherwise it's me talking today, or anybody else? Okay, so RNA doesn't have proofreading mechanism like DNA. Your DNA has proofreading, so when you replicate in bacteria or human, anybody, you've got this proofreading mechanism built in, and it's correct as it replicates, right? Now DNA replicates, your cells grow from replication, and RNA does not. So as it replicates, and our genome only has 4 nucleotides, ACTG, right? Basic biology. As it incorporates, A meeting with T, it makes mistakes because they make mistakes. And RNA doesn't have proofreading mechanisms, so it makes lots of mistakes. That's key important thing. It has an integrate gene that allows it to integrate its RNA genome, convert to DNA, integrate itself into the host, so it takes advantage of the host replication machinery to make more of itself. This is classic of all viruses. It cannot replicate by itself. It actually relies on a host cell to replicate. That's why it's called a virus. It's not even alive by itself. It's amazing organism. Rapid replication, so with potential for genetic diversity because of the ability to have mutation. And it can lie dormant within the cell for many, many years, especially in resting memory T cells for many years. So when you're infected, you may have a retroviral syndrome. You may or may not know about it because it's just like any other virus infection, like a flu, and then 10 years later, you develop severe immunodeficiency.
Question about antibody production, because based on RNA, so wouldn't that be a problem in replicating cells?
So is that a problem with initiating antibody because it's intracellular, so it can shield itself from being recognized by the host antibody? Absolutely, yeah. So intracellular pathogen is tricky for antibody to develop because it's kind of inside the cell. However, all these intracellular pathogens, when they get into the cell has an ability to chop the DNA up and present it. There's antigen presenting cells that will do that, chop it up and present, hey, you got a foreign thing. And that's recognized by different mechanisms that can initiate immune response. So it's still okay. The question is whether antibody that is produced is neutralizing the virus in different cells, right? Whether the antibody is produced is effective in neutralizing, that's a different question. And that's the question with HIV because we know that antibody that develops that we can detect, to make a diagnosis of HIV is not neutralized. And that's why vaccine doesn't work for HIV. Because vaccine is based on antibody response, right? So lots of our vaccine principle is you inject the pathogen in your body and allow your body to remember it. And so the next time you see it, you're gonna mount an active immune response, but HIV does not. So the antibody that is used that you recognize, you can detect, not neutralizing. Okay, so there's two different HIV types. So the HIV-1 is the one that is caused a worldwide pandemic, currently 40 million people. There's HIV-2, isolated mostly in West Africa. It's called much more slowly, but otherwise simply quite similar, but it's less virulent. And it hasn't, because it's less virulent, it stays in West Africa. Okay, let's talk about the distribution of different clays. Yep.
Just as a specification, how much more slowly does HIV-2 cause AIDS? Because it's variable in HIV-1 as well, right? When you develop AIDS, depending.
How much? What is your first question?
Sorry.
Speak louder.
Sorry. For HIV-2, how much more time does it take to develop AIDS compared to?
You can have it in just chronic for years, 30 years, and some immune deficiency much slower rate. Okay, so HIV evolved into these multiple different clades. There are actually 13 different clades around the world by two mechanisms. First is mutation, we talked about already. Change in single nucleotide because it's an RNA virus. Number two, you got two viruses that are similar that we combine, right? So basic biology, when you got similar genome, it comes in contact with each other, it's going to switch. We call that recombination. And so you then cause recombinant strains. There's several common recombinant clades out there. So A, for example, is in Central Africa. B is what's causing HIV in America and in Western Europe. C is in very much South and Eastern Africa. And AE recombinant is in Southeast Asia. So you just got the postulate because of human transmission and postulate and become a dominant peptide in different geographic settings. So this is the structure of HIV. Wonder if you can see mine. So the structure of HIV is very simple. Yeah, it's very simple genome. It has a GP120 and GP41 transmembrane protein. It's basically an anchor protein, as you can see, this beautiful anchor of the membrane, just a deep membrane structure. Without these proteins, it's going to be stopping, right? And these are the proteins that are recognized by the antibody. Because it's exposed outside, antibody recognize it. This is how we make the diagnosis of HIV. We recognize these proteins. And then it has the matrix protein here. It has a spore protein to keep the structure. And then inside the spore protein, it just has three things. One is a reverse transcriptase that allows the virus to transcribe itself from RNA to DNA genome. It has an integrase to allow the DNA genome to incorporate inside the whole genome we talked about. and it has the RNA. It has an RNA virus, right? We talked about, and it has a protease that allows it to package into the virion. So very simple virus, very simple structure, but highly, highly efficient. And so here's a picture of the virus, right, with the GP41 and GP120 that I talked about, transmembrane protein that bind to our CD4 positive T cell, right? So in your T cell, you and I have about 30% of our T cell, white blood cell, has CD4 positive in it. We'll talk about it in a little bit. And the virus, this protein binds to the CD4, they recognize each other, and then it's fused into the CD4. So this is how it works. You need a CD4 positive cell for the HIV virus to bind and to cause infection. And the way HIV works in replicated cells, we talked about its RNA genome, it fused with the CD4, this protein, right? Fused, get into the cell. Immediately, it uses reverse transcriptase gene, or protein, to allow transcription of RNA to DNA genome, of RNA single strand to double strand DNA. And then that gets incorporated by its integrated protein that we talked about into the host nucleus. So this is our T cell right here. And our nucleus is really an engine. It's like a factory making more of itself. It integrates itself and use the machinery of the host to make more of itself. So here you go, make multiple replicates. And then the protein of the virus packages into these virions and release. And every day you have 1 billion virus release. In a patient infected with HIV, every day they make 1 billion copies of these virions. And these virions, with replication, can be very, can be errorable. So it makes a lot of error every day. This is an electron microscope picture of the CD4. This is our CD4 T cell here. And these gray things are the virions, the virus. You imagine these are all viruses blurring out of the CD4. Here's an electron microscope picture of all these virions blurring out of the CD4. And tons of, these DNA packets waiting to be packaged by the factory to be pumped out. Okay, so that was virology. Any questions? No? Let's move on to immunology and pathogenesis. So we know that HIV infects CD4 T cells. And CD4 T helper cell sitting here, it makes a TH1 cell and TH2 cell. TH1 is responsible for cell-mediated immunity. So in other words, it's taking care of intercellular pathogens, cancer, TB, and all the viruses that infect inside the cell. TH2 is responsible for humoral immune response. In other words, making antibodies to fight extracellular antigens. For example, bacteria are extracellular pathogens. Some fungus are extracellular pathogens that can be taken care of by antibodies very efficiently. So HIV, in fact, it is really considered like an orchestra director of your immune system. It targets the orchestra director, so the whole orchestra is messed up. You don't even know how to play which part, and you're confused. So this is why HIV is really important. Target is really important component of our immune system. Okay, I'm going to skip this slide. We talked about cell-mediated, humoral-immediate immune response to HIV. And we'll talk about how HIV subverts the immune system, right? First, we talked about infect CD4 with control, orchestrated immune response. It integrates itself into the host DNA, so it's inside the cell, and the immune system don't see it very well. We talked about it has high rates of mutation. We talked about it hides in tissue, but not readily accessible by immune system, and it's induced cytokine environment that makes the virus more able to replicate. So it kind of activates the immune system further. So it's really a sophisticated system to subvert the immune response. as soon as you're infected with HIV, within essentially 3 days, it disseminates to all organ systems. That's how fast it goes, and that's how it's very difficult to stop HIV from infection, giving treatment early. This is why people try to give treatment way early, particularly with infant transmission. Like you know the time the mother delivers, and you give medicine very quickly at the very beginning. First few hours of the newborn have been shown, demonstrate that you can suppress HIV production. So if you do it very quickly, you reduce the burden of HIV at the beginning, and maybe reduce its ability to actually get into these safe havens, including the brain, the deep spleen, lymph node system in the gut. So in kind of safe haven place. So you treat fast, but how do we know? We don't know that you infect. So that's the problem. So you can't stop it. What is the role of cellular immune activation in pathogenesis? So we will just very superficial knowledge here. HIV-induced immune activation, and it does it through basically when it gets in, it gets most of HIV is actually in our lymphoid tissue, and lymphoid tissues are staying very much in the gut, in the where the boundaries of the human body and the environment. So in the gut, in the mucosal space, it's when you come in contact with the outside world. You've got a lot of lymphoid tissue and HIV concentrate there. What it does cause is inflammation that causes leaky gut, leaky mucosal. And when you have leaky gut, bacteria from the gut sneak into the bloodstream and cause activation. There's a lot of, when you got bacteria in the blood, it causes activation. So the immune system is constantly activated. And that's the key pathogenesis of HIV. It's not just immune deficiency. By suppressing your T cells, which cause immune activation, that you learn that it's causing all sorts of different things, cancer, non-HIV associated condition like cardiovascular disease, CNS problem, dementia, all sorts of different organ problems because of constant immune activation. So not just immune suppression, but also immune activation. Just keep that in mind. All right, so that's very superficial introduction of the immune response to HIV. Any question there? No questions. All right, let's move to natural history of HIV. So transmission happens through sexual transmission, as you know, through the general anal oral mucosa, through sharing of needles, syringe to an injection, mother to infant, accidental occupational exposure, injecting yourself, when you're giving somebody, taking blood and then inject yourself, or step onto a syringe from somebody who used drugs and throw it on the street, and you step on it, and you steal some dry blood with virus on it, and through blood transfusion. So these are known pathway of transmission. In terms of laboratory marker of HIV, we talk about antibody to diagnose HIV. You can also do an HIV testing. You can actually measure HIV replication, right, directly in the blood. We call that viral load. And you can measure CD4 count. So you and I have about 500 to 1200 CD4 count per milliliter of blood. And an HIV patient who is infected chronically has very low CD4 and, can be from 0 to normal. But the CD4 count tells you how long the patient, roughly how long the patient been infected, if it's a chronic infection that we talked about. So there's a window period after you've been exposed. So within the window period here of 2 weeks, nothing's happening. So from times of exposure to the 2 weeks, you can have symptoms, but you don't really have any antibody response yet. So there's a window, when somebody infected, you can do HIV antibody or virus and it's negative. So there's a window period. You have to wait. If you really worry about HIV in somebody, you may want to, you have to repeat the test a few weeks later when they already develop antibody response, and enough virus that you can detect in the blood. So that's the only thing I want you to get out of that slide. This slide tells you about the natural history of HIV, which we talked about. So if you look at the HIV virus here, yeah. So in black is HIV viral replication here on this side, virion copy. When you first infected, look at how much virion is being produced. And then, sorry, it's a blue thing here, the light blue. So it basically rise up, and then the immune system begins to kick in with antibody. You develop clinical latency over 5 to 10 year period, depends on the host. So young people can develop end-stage AIDS very quickly, in a few years actually. But most people, 5 to 10 years. And so the virus and the immune system go into some sort of equilibrium here, and it stays about same until at the end, when you develop AIDS, when the virus begins to go up and up, and it's called death. In terms of HIV, CD4 count, as you can see, CD4 count, your normal CD4 is about 1,000. When you infect it, initially kill your T cells, so it's going down to about 500. And then when the period when you got critical latency, there's a balance between the virus and host immune response, so it kind of balances it out until the end when CD4 begins to go down, 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 down. This is when a lot of people develop symptoms and where opportunistic infections happen. So far, we've talked about HIV is a retrovirus capable of integrating into the host genome, establish chronic infection. We talked about HIV classified into subgroups, clade, because it's able to mutate and recombine itself as it spread in the population. It's become dominant in different geographic distribution. We talked about important steps in the life cycle of HIV. We talked about cell-mediated immunity. We talked about how HIV evades the host immune system and how HIV activates the immune system to increase its own replication, but also cause pathology in the host. So that's just a quick summary of what we talked about so far. Now we're going to talk about opportunistic infection. So this is the CD4 count that we talked about from 1,000 as a normal person, and over a lifetime of patients begin to go down. Over 5 years, 10 years is when you begin to have these severe infections. So the kind of infection that these patients get depends on the CD4 count as they go. So the first 5 years, they get kind of inflammation, Guillain-Barré syndrome, you have all sorts of weird autoimmune phenomena that target the platelet cells. They have all sorts of myositis, muscle, Bell palsy, just weird immunological phenomena, because at this time, there's a lot of host and pathogen interaction that's causing host immune response to the virus, and it causes sort of equilibrium. But in the latter part of the latency period is when you begin to get opportunistic infection. Predominant thing is patients develop warts, they develop the HPV virus-associated disease, tuberculosis, lots of herpes infections, herpes in the mouth, all sorts of bacterial infections. They can develop oral candidiasis or thrush in the mouth. In fact, that's the most common. Actually, looking on the cohort now, we saw a lot of oral candidiasis in the cohort. So lots of the patients coming with yeast in the mouth. And when it gets to the advanced stage, when CD4 is less than 200, is when they develop TB, disseminated disseminated fungal infections, and severe viral infections, disseminated all sorts of different infections and death. Just give you pictures of these conditions so you easier to talk about. This is oral candidiasis. So Candida that colonize our mucosa develop invasive disease causing mouth sore, and so on. This is easily treated. It can involve the entire GI tract, so patients cannot eat. This is how they really come in usually. They can have gingivitis, very severe gingivitis disease because of, again, as I mentioned, there's a lot of immune response and activation going on in your mucosal space. So in your teeth, when you've got lots of bacteria and host immune response, there's a lot of immune system reaction, hyperreaction going on that's causing inflammation. You can develop herpes zoster. This is zoster. We call it shingles as a latent, so latent herpes virus that reactivates during HIV. You can have these all sorts of different chronic skin conditions that we don't understand. This is not infection per se, but it's post-immune response in the skin. Tuberculosis, right? We talked about TB. Here you don't see much TB, so you're not worried about it, but in Asia and Africa, this is the most common. Well, it is the number one killer of patients with HIV. Number one killer, TB. And then you got pneumocystis pneumonia. It's the fungal infection that I talked about that we first diagnosed HIV in this country. These are little cystic pneumocystis in the lung alveoli. When you do go down here and get a little sample, this is when you see all these fungus that can cause severe lung disease there. Cocciococcal neoformis is another fungus that causes meningitis, and number one killer of patients with HIV in many places in Africa. Histoplasmosis is another disseminated fungal infection that affects people, particularly in Latin America, in this country as well, and also in Southeast Asia, are disseminated. These, again, in their blood community, you can see all these fungus inside the cell. Chylomicrosis, which is a disease that I'm working on, very similar to histo, is causing disseminated infection. You can identify it in the blood. These are major killers. You can develop a parasitic disease called toxoplasma. It's a parasite that you and I, probably about 25% of the U.S. population has been exposed to toxo from having cats. And you and I will be fine because we got a very good immune system. But in HIV, they reactivate and cause basically abscess in the brain, and they develop seizure, and they can come in with seizure to death. They can develop this called progressive multifocal leukoencephalopathy, which is caused by a virus that you and I can have, and no problem, latent infected. But in HIV patients, reactivate and cause severe inflammation in the white matter of your brain, and they cause all sorts of balance problem. They're unable to eat and can cause seizure and really progressive. There's no treatment except for antiretroviral therapy. You can develop Kaposi sarcoma. We talked about skin cancer, cancer caused by herpes virus. And you can develop this HPV, human papillomavirus. Again, many of us get through sexual contact. And for HIV, they can have horrific human papillomavirus infection. These are just verruca caused by this also called cancer here. So this virus is also oncogenic, like many other herpes, and cause cervical cancer, anal cancer, etc. So the field is to struggle with dealing with these complications of HIV. You can have CMV. So CMV is another herpes virus family. There's 8 of them. Herpes 1, 2, herpes zoster, herpes CMV, herpes human virus cases called Kaposi sarcoma that we talked about. This is CMV, causing disease in the eyes, in the lungs, in the gut. These people go blind because of CMV retinitis. You can have lymphoma in the brain, and so because of the immune system abnormality, they develop these big, huge brain cancer from HIV, very, very common. So anyway, in addition to the opportunistic infections or immune suppressive complications, we talked about non-AIDS associated complications because of immune activation, right? So some of them are early heart disease. These patients have more complications, they have much more higher incidence of cardiovascular disease, heart attack, heart stroke, etc. At a younger age, much younger age than a normal human counterpart. They have cognitive impairments in the brain because of inflammation in the brain. They have lipid problems leading to fat changes. So you can see these patients and they have temporal fat, they're moving their fat around in different places. So their facial features are different. You can tell as a clinician that they have fat changes in their body shape. You got bone thinning and fracture. You got worsening liver disease, particularly in those with co-infection with hepatitis. So hepatitis B and C, you co-infected with hepatitis. With HIV, the progression to cirrhosis or cancer of the liver, hepatocellular carcinoma, is much faster with HIV co-infection. You have all sorts of different cancers. We talked about lymphoma, we talked about cervical cancer, we talked about other cancer. You can have lung and kidney diseases, and you can have accelerated aging. So this is an infection that causes everything that you can imagine, not just opportunistic infection, but lots of chronic disease due to chronic immune activation. Okay, 8 more minutes. Last few slides, we did it. So now just very quickly on treatment and prevention. As I mentioned, this is one disease that we could be very proud of. Look at this. This is death per 100,000 population compared to accidents, cancer, heart disease, suicide. Look at HIV. Everything goes flat line. Like, as I mentioned, lots of infectious disease that I'm treating haven't changed. I still deal with patients in the ICU with a 30% mortality when I trained 20 years ago, and 20 years later, it's the same. We haven't made a dent in outcomes, but HIV, humongous outcomes. And so that's why the field is big, that's why it's important. We make a huge difference in that. So treatment, there's all sorts of different, I'm not going to go through every single thing, but we have mechanism to inhibit binding of HIV to the CD4. We can inhibit the fusion, even if it's bind to the CD4 with the GP41 and GP120. We can inhibit fusion into the membrane. And then step 3, we can inhibit reverse transcription, which is very classic. We still use these drugs, reverse transcriptase inhibitors. They're toxic because it inhibits DNA synthesis and it's toxic to human cells. We inhibit integration of the transcribed DNA from RNA to DNA. We inhibit the integration into the nucleus. This is now the first-line treatment of HIV in the world. So even in Africa, Asia, integrase inhibitor is now the #1 treatment because it's so potent, and it's only been around for the last 10 years or so, but it's changed tremendously. We used to have to deal with this drug. Now we just start with integrase-based inhibition. It's very potent, and it really takes down virus multiple fold down within 2 weeks. So before you kind of get slowly down because the viral decline, now you get like this in safe class. So it's very potent, very high barrier, genetic barrier to mutation. So integrase inhibitor is really a fantastic drug and well tolerated. Yes.
Sorry, you just mentioned well tolerated. That's what I was going to ask about. Does the integrase inhibitor have any adverse effects on the cell level because of
side effects? Very little, actually. very well tolerated. So we're now able to make these drugs available to Africa and Asia, to the world, which is less than $100, maybe about $60 per month. But that's after 2 years of now it's generically made. Very little side effect. There's some side effects, but compared to other drugs like reverse transcription, lots of toxicity. Fusion inhibitor is used only by subcutaneous injection. We don't use anymore. Inhibit binding, we don't use very much anymore. Now the main thing is integration inhibitor, reverse transcriptase inhibitor, and protease inhibitor. So very little side. Number 5 is we can inhibit replication once it's already transcribed. So we can inhibit replication, we can inhibit assembly, we call protease inhibitor. It inhibits assembly into the virion, and we can inhibit the body. These are new capsid inhibitors that are right now being made as long-acting drug, capsid inhibitor, lenacapavir. You can use it as an injection every 6 months. So now we're moving from taking the drug multiple times a day. My patients used to take a whole handful of drugs with so much side effect, causing so much problem, to one pill once a day, which is now, but we're moving sort of away slowly to injection long term. So you can actually in the future, within a few years, have injection every 6 months. And that is the new exciting era. So anyway, treatment strategy has evolved over time, yes.
So with this new drug, is there monotherapy or both using combination therapy?
2 combination therapy. So yeah, I should step back a little bit. Lenacapavir, the capsid inhibitor, we still need to take it within combination of it. So we always use combination. In patients who've already biologically suppressed, there's plenty of data to show that you can now use dual drug only. You don't have to use triple drug. Trying to basically get away with reverse transcriptase inhibitor because they have toxicity long term. Kidney toxicity, for example, tenofovir causes kidney toxicity, and 3-TC, blah, blah, blah. So we're trying to get rid of this and just have integrate in one more drug, dual therapy in the future. Okay, so the treatment strategy has evolved from early 80s to no therapy, monotherapy, dual therapy, to combination therapy, right? And in the 90s, David Hall was like, we need to hit hard, hit early, and then, he basically said, let's just hit hard, hit early because of the complications that they've seen in the laboratory. And then people get started, but the drugs are so toxic. So people step back and go, no, let's defer therapy. So in the early 2000s, there's trials that look at delayed therapy. So the famous trial was called SMART trial, where they delayed therapy until CD4 count dropped below 350 to stop versus therapy right away. And that trial was revolutionary because we learned that by delaying therapy, you're not only causing more opportunistic infection, but more death by other causes, like cardiovascular death and other death. So we learned that you should do it before therapy. And in the early 2000s when we begin to come up with better drugs, and now the pendulum go back to hit hard, hit early, and now we're moving to treatment as prevention. And that's another trial that was run sponsored by the NIH, actually coordinated by UNC here down the street. It's one of the major trials that show prevention as a treatment strategy. Treatment strategy as a prevention for HIV infection. So what are the effective HIV prevention? There's not one size fits all. There's all these that are available, right? So as you go through and hear about HIV, how do you prevent? You prevent by education, behavioral modification. That alone is not enough. You cannot tell people to not have it, right? That doesn't work. condom, clean syringe, drug abuse treatment, people who are addicted to drugs, interruption of mother to infant transmission, start treatment early in mothers. You've got topical microbicide, male circumcision has been shown to reduce HIV infection, 50% reduction. Treatment of other sexually transmitted disease to reduce activation, the mucosal level, pre-exposure prophylaxis, red PrEP, people who have high-risk behavior leading them preventive strategy, and vaccination is obviously the holy grail of HIV. And lots of work are being done there. Scientists monitor. My colleagues from the UNC here run this trial that was called the Breakthrough Prevention or Breakthrough Intervention of the Year in Science. Treatment and prevention of HIV is a trial that is run to show that treatment prevents HIV transmission in high-risk couples who are supported, one with HIV, one not. You treat them, they won't. If they become biologically suppressed, they will transmit HIV by that. So it's important to take medicine and you won't transmit. And if you take that at population level, you won't be able to transmit, right? So that's the key. We know how to interrupt treatment. We have strategy to do it, but implement it in the population to be able to make a dent into the 7,000 new infection program is a challenge. And so this is to speak to implementation science being very important. You could sit in the lab, do all these things, you could show these trials that improve, but if you don't implement it, don't understand how to implement it in the population, you don't make a dent in public health. Yes.
Sorry, I just wanted to is this the same as the use?
Yes.
Okay.
Yes, undetectable equals untransmitted. So that's U equal U. Okay, thank you for bringing that up. So I just wanted to show you where we are. In Africa, you still have a huge gap in reaching 95 goal by the UNAIDS, meaning 95% of people infected know they're HIV, 95% on therapy, 95% biologically suppressed. We're still far from getting there. For example, Southeast Asia, only 55% are biologically suppressed. So we still have huge gaps in light yellow here in Africa and Southeast Asia to cover. And this is our new HIV incidence. You can see that it's kind of plateaued off. We're supposed to keep going down, but we're just right here, you know. Even with all the interventions we have, still got new infections. Number of new infections is still very high, and the number of deaths is still, again, 630,000 people deaths per year here. And so everything is kind of plateauing off. There's lots of work to be done. So the challenge for you, new generation researchers, quantitative science, working with investigators here. We need HIV infection awareness, right? We need advanced HIV disease management, opportunistic infection and death, treatment, side effects. Lots of patients on treatment have fatigue and non-adherence. So long-acting may be the way to go. We talked about implementation of these effective prevention strategies. Implementation science is important. We need to research on non-AIDS complication and aging, mental health stigma disparity for their well-being, HIV vaccine, and HIV cure for people who are already infected. How do you cure them from HIV? So those are the challenges that we face now in the epidemic still today. So that was it. I think we made it a little bit over, 4 minutes over. Thank you so much for your attention and happy to talk more with any questions.
So for someone who has like well controlled HIV and is adherent to their medication, like how much is their life expectancy to be reduced?
The same. We've already shown that if you get on therapy, and and you get over the very critical time. If you get detected early, of course that's easier, but if you detect late, you've got the 6 months very critical time of severe complications, opportunistic infection. When you get over that, you have a normal lifespan. Of course, you can have other complications, like cardiovascular disease earlier. Your mobility may have the same lifespan, but your mobility is high. You have more incidence of these complications. That is a result of inflammation. Yes. Gentlemen.
Like someone in Africa, like maybe someone living with HIV in Africa, how are they able to like place them on antiretroviral? Because do they pay for it? And for someone that doesn't really like maybe have the money or something, what are those measures and how are they?
What are the barriers to treatment?
Yes.
Drug now are quite cheap, and in many places in Africa, this program is free drugs. Many places, including South Africa, which is the richest country in Africa. Drugs are free. So HIV drugs are free globally, including this country. So you can get treatment. The issue is stigma. That's an issue. So you have HIV, you have to go to that particular clinic, and everybody knows that clinic is for HIV patients. And so if you happen to have, let's say a lawyer have HIV, you don't want to go there because everybody knows you're HIV. That's the problem. But a lawyer can pay for their drugs, but if you've got a normal person can't pay for the drug, they don't want to go there because of stigma. They kind of avoid. So that's the problem. The problem is not money per se, stigma. And HIV care is still very concentrated. I think at some point, HIV treatment should be given by primary care, because that's the only way for us to destigmatize disease. Right now in these major countries, it's still because of the program. Because it's complex actually, right? Taking care of them is a whole package and it's complex. And so primary care doctors don't feel comfortable with it. At some point, true decentralization means that you give it to the primary care nurse practitioner, maybe even nursing to give it, and only refer patients to specialists when needed. That way, nobody needs to know you HIV. But HIV still evolves so fast, and I can say during my training, there's HIV drug resistance problem. You have to understand when to test for drug resistance, how to interpret the genetic test. It's complex for PCP, even complex for an infectious disease who don't do HIV. So it's a bit challenging, but at some point when we get to the level of long-acting, you just inject and the patient will do well because integrase inhibitor is so good at suppressing the virus. If you suppress the virus well, nobody's going to develop resistance. Resistance happens when you don't suppress well. You have an issue of biological, going on. That's when the virus develops. That's when the virus evolves. It's evolved when it's replicated. But if it can't replicate, it's not going to be. And so I think at some point, long-acting, we should decentralize to primary care. And that's a huge other step of educating, treatment, changing the way people think. But I think that is when we're going to make a dent, because the issue is stigma. Yes.
Sorry, you mentioned developing drug resistance due to those highs and lows in the level of drug resistance. And you also talked about moving from triple drug therapies to double drug therapy. Does that increase the chance of developing resistance since you're treating it as
Right. So at the beginning, when we use mono drugs, we learn very quickly within a month or two virus develop resistance to AZT. We learn very quickly, oh, it's great for a few months, and then boom. Then we did two dual drugs. It's was good. Oh wow, you know, you can target by 2 different mechanisms, and it's sustained for a year, and then oops, resistance developed. Not until we did triple that, 3 drug, 3 mechanisms, that we learned that we can suppress the virus. So now we're swinging the other way, trying to do less, but it's different because of integrase inhibitor is so potent that you get the virus down to undetectable very quickly. It used to take 4 months, now it takes only a few weeks to go down undetectable. So when you go down like that, when you go down like this, if this is a slow, you still got evolution. If the patient during the first 4 months is not adherent, this is the problem with resistance. You know, who does take the drug religiously 100%? Who does? If I give you 2 weeks of antibiotic, who take your drug 100%? Not missing a dose. Probably nobody. I'm so bad at it. I forget. I'm the worst now, so I totally sympathize. So 4 months, you got the virus that's going down like this, meaning it's still replicating, and you take and you don't take, you forget. Your drug level is up and down, up and down, up and down. This is when it's perfect environment for resistance. But now it's a different story. Now we got integrase inhibitor that gets the slope down like this, not like this. So it's down to a few months, and only 1 pill once a day, triple drug in 1 pill. So it's easy for people to take once a day. It's less likely to forget. Drug level is less likely to fluctuate, and it's so robust that you get down to undetectable so quickly. And when you become non-detectable, that is when you can peel off and you can just suppress with 2 and you'll be okay. So I think that understanding is really important what you're doing, not just how many drugs, but understanding the dynamic of the decline of virus and the adherence of the patient. So I think you can peel off, particularly with long acting, potent and long acting.
Oh, so it's sort of like you start with a triple drug therapy and then it's safer to move to double drug, and that's better than just starting with 2 drugs.
Yes.
Because that would be risky.
Absolutely.
Okay. And then, I don't know, for my project this summer, with Dr. Katz, we've been looking at islatravir, also he said was the more potent drug than tenofovir. I remember you talking about how tenofovir has side effects with kidney disease. So, is that something that might also be helpful, where instead of doing away with tenofovir because it has so many, using something that also has side effects but is more potent, so you don't need to use as much of it as you would a less potent drug.
I'm not sure what you mean by don't use as much of it.
Or, I mean, it's potent, right? So you probably need like lower concentration.
Yes, that's all PK then, yeah. Whatever it is, you need to maintain, how do I say, suppressive level. You have to be able to be suppressed. You're able to, whatever level that you can achieve. So that's more of a PK dynamic. Yes?
When you treat HIV-related disease, how is it different for people living with HIV?
Okay. Probably the same. You know, it's the same disease. It's just different in that it happened earlier for HIV. So the way you treat it would be more, I guess, more proactive in screening for, paying attention to, rather than, so we see, for example, cardiovascular disease in HIV patients in much younger age. Cardiovascular, like heart attack and stroke, happen in older men. Older men smoke, hypertension, cholesterol, blah, 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 right? Women too, but these are the risk factors. In older men, means above 60. Now in HIV, you get cardiovascular disease in the 40s. And so it's the same disease, and so the treatment for them, managing them when they've already had the disease is the same. but to prevent it is a different story. So there is a great question to this new is that we just last year came out with a big trial. I forgot the name now. People, I don't know, I forget the acronym, but it's a big trial in cardiovascular disease where they give lipid lowering drugs, statin drugs. Statin drugs inhibit enzyme that synthesize cholesterol, so it's reduce your cholesterol. And also, statin drugs is anti-inflammatory. It has some anti-inflammatory effect, and it's reduced cholesterol. So it's kind of a double whammy against cardiovascular disease. They did a trial in multiple countries in Africa and to give statin to everybody above 40 years old versus no statin. And the incidence of cardiovascular disease is essentially different. And so now we're implementing that, trying to give statin drugs to everybody. That's a prevention strategy, trying to reduce the risk as much as you can by reducing modifying the risk by giving these preventive strategies. So that would be a very vibrant area of research, for example, in prevention of these by anti-inflammatory medicines that are benign. Not all anti-inflammatory medicines that you could say benign, but statin drugs are quite benign. And you and I can drink it in the water and it helps you cholesterol, anti-inflammatory, for example. There's a lot of modalities, lots of research, lots of things you can ask to do. Is there another drug that can be used? For example, aspirin has been shown to prevent cardiovascular disease in older men. And that's why men who are above 60 are advised to get low-dose aspirin because it's been shown to reduce incidence. For example, can we do that in HIV patients? It hasn't been done yet. I'm just pulling that out of my head. There's so many interventions we could do. Think about. Yes?
Okay, so after after living with HIV, after you achieve the suppression level, the viral load was suppressed.
Yes.
Did they switch to a different drug or did they continue taking the same?
We continue the same. We continue the same for life. And but now the strategy of switching is things that are less toxic. And so as we come up with new drugs, we begin to switch these people who are biologically suppressed and stable on less toxic drugs that have less side effects. For example, less side effect on weight gain, less side effect on lipids, less side effect on kidney, less side effect on bone, for example. Tenofovir is classic to cause kidney and bone problems. So we kind of switch that. Certain drugs like protease inhibitor has more side effects in terms of lipid abnormalities, so we switch that to something more potent. So it's more of an optimization strategy. Okay, no more questions? Thank you very much. I hope that was useful.